Please be advised, this is a public meeting, and the staff of IFSP and our presenters appreciate your attendance this evening, along with our council members. Since this is a public meeting, please refrain from sharing personal information. Post-meeting content will be available on YouTube for later viewing. My name is Rhonda Gaines, and I'm the IFSP Community Coordination Supervisor. This meeting is presented by IFSP's Regional Councils. If you have questions about IFSP funding, please visit the My Life, My Community website, and Rachel will provide that link in chat. Typically, we have regional breakout sessions during coordinated council meetings. However, that will not be the case this evening. This topic and how to access services is fairly consistent across the state. Instead, we have regional REACH representatives to help answer questions that may be relevant to your particular area. Okay, we will begin the meeting. We have captioner Janelle Kula from Virginia Hamilton Relay. Rachel will provide the link in chat for anyone who may need this resource during the meeting. Our educational topic tonight, mental health supports for people with developmental disabilities, featuring presentation from VJ Petillo of REACH, Central Region. REACH stands for Regional Educational Assessment Crisis Services Habilitation. Also joining later on in our meeting for question and answers are 7 additional REACH team members. Here are the ground rules for the meeting. Please be respectful of our main presenter, regional panelists, and other attendees. Mute your microphone when not speaking. One speaker at a time. Speak so that everyone can hear you. Please use chat for all communications. IFSP will collect your questions and prioritize them for the Q&A session later on the agenda. Identify your region when you are asking a question. Please be advised, there is no option for private chat messages during this meeting. All comments entered into chat can be seen by all attendees. If you cannot use the chat box, please raise your hand for assistance. If you have a question that is unrelated to this educational topic, please email IFSP support, and Rachel will provide that link in chat. Okay, please respect one another's ideas, opinions, and communicate in a supportive way. Mind your personal technology by silencing devices during the meeting. You are encouraged to turn on your camera when speaking so that we can see your faces. And last, this is usually not a concern, but we like to inform that IFSP may remove anyone who is disruptive during this meeting process. Okay, so now I'm going to hand over to Heather Hines, the IFSP Program Manager. She's going to give us an overview of IFSP service components.
Thanks, Rhonda. And welcome, everyone. And we're so appreciative of our speakers being here. This is a very important topic that I know we all want to learn more about. But I wanted to tell you a little bit about IFSP, and then we'll get right to why you're all here. But for those of you who are not familiar with IFSP, we are the Individual and Family Support Program. The program primarily focuses on supports and resources for individuals and families, regardless of their age, with a developmental disability who live in the Commonwealth of Virginia and who are on the wait list for developmental disabilities waiver. While the IFSP funding program is the one program that is expected to always target people on the DD waivers waiting list, our other programs are available to people regardless of their waiver status. So people without waiver, many of them are available to people even if they're not on the wait list, anyone that needs information. IFSP provides financial resources with our annual funding program. So you'll see here we have our 4 components. The individuals who are on the DD waivers waiting list can apply for funding for items and services that support them to continue to live in their communities. This program is typically once per year in the fall. So I know a lot of people have a lot of questions about that program, but feel free to reach out to us separately, like Rhonda said, at our support box. Another part of the IFSP is our direct supports to individuals and families, including family mentoring opportunities through our partnership with VCU's Partnership for People with Disabilities Center for Family Involvement. Many of those folks are here with us today. And our peer mentoring opportunities through our partnership with the ARC of Virginia. Our partnership with VCU also includes LEAP, which is Leadership for Empowerment and Abuse Prevention Training. Regardless of an individual's waiting list or waiver status, you can access these programs. IFSP partners with Virginia Navigator to develop and maintain the My Life, My Community website. You can find information on services and resources here, regardless of waiver status. There's also a toll-free number, which is 844-603-9248, where you can call and speak to a live person. And the people on the other end of the phone are incredibly knowledgeable and helpful. They help people navigate the website and answer all kinds of questions and help people get referred to the information that they need. And the IFSP Community Coordination Program, which is our councils that are putting on this event, it's a partnership made up of our IFSP Regional Councils, which is 5 coalitions of individuals. It's made up of people with developmental disabilities, family members, caregivers, and professionals, all working together at a grassroots level to increase supports in their communities. Over 50% of our council members are either people who are on the DD waivers waiting list or are family members of people on the DD waivers waiting list. And again, I said it's the community coordination program is the partnership of the regional councils and the state council. Our IFSP state council is a coalition of individuals, family members, and caregivers that serves as an advisory board to DBHDS. Another essential part of IFSP is our marketing and messaging. And I'll just highlight a couple things here. We share information about resources and individuals with individuals with developmental disabilities, families, and the community at large. Among the many communications we send, I'll highlight our First Steps document, and that can be accessed on the My Life, My Community website. And it's also included in our annual mailer, which we send to everyone on the wait list every year. It includes an overview of the DD system, and this guide was developed to help people and their families understand resources, supports, and services that the Commonwealth offers to people with developmental disabilities. It also includes how to access the waivers, links to My Life, My Community, our one-stop information website, a summary of the IFSP, and a list of resources for people who are on the wait list, and lots more is in there. But we've developed it and we send it out and get it, and are really working hard with our council members to get that information out to people across the state. And we also send a monthly digest to our email list. Our digest includes information about resources, training opportunities, coming events that may be of interest to people. And if you'd like to see those monthly emails, please see the link in the chat. Rachel, I think, has already added that for you. So that's just a brief overview of what we do. And one of our favorite things to do is work with our councils to share information and REACH and mental health supports for people with developmental disabilities was a hot topic, one that came to the very top of the list, and we wanted to make sure that we could get you all the information that you need. So thank you so much.
Thank you, Heather. Now we'll just get on to our main presentation. Again, our educational topic is mental health supports for people with developmental disabilities. Our guest speaker is VJ Petillo, who is an endorsed positive behavior support facilitator and currently the system trainer for Region 4 REACH. Since starting in the field of IDD in 1991, he has worked in a wide variety of service settings, including residential services, supported employment, exceptional education, case management, private practice as a behavioral consultant, and crisis support. A significant part of VJ's work throughout his career has involved directly providing and/or developing behavioral supports. VJ has master's degrees in rehabilitation counseling and theology. He was endorsed as a positive behavior support facilitator in Virginia in 2006. VJ also has a clinical certification from NAD, National Association for the Dually Diagnosed, one of the leading organizations for education, consultation, and training related to IDD and mental health conditions. Outside of REACH, VJ consults with IDD organizations and on individual cases. We are very pleased to have him here, and I will let you take over, VJ.
Okay. Well, thank you. Very happy to be here. Thank you for asking, Rhonda, and the whole team. We're always, by we, I mean REACH, which we'll go into more detail about the different regions and the different things that REACH does to support people with intellectual and developmental disabilities in the communities across Virginia. But we at REACH are always looking for opportunities to continue to provide education, training, presentations, really just anything we can do to help support rising the tide of the supports and services that are provided in Virginia for people with these very complex needs. And so it's wonderful to be able to do this tonight. This is a really great and rare opportunity, actually. So thank you. So there some of my call REACH colleagues are all here from different regions as well. And so we'll get to, you all will have an opportunity to ask questions later. And as those questions come in, if, the experts from the different regions should be able to chime in and help you, we hope help answer those questions, or at least, take a note if we can answer a question and try to get an answer to it. So we'll be meeting all of them a little later as well. So I'm going to share a screen here, and I know my friends at IFSP will let me know if this is working or not. Can you all see it? Oops. Can someone let me know if you can see it?
Not yet, VJ.
Yeah. Not yet? Okay.
It looks like it's trying to come on, but not quite.
There we go.
Yet.
Okay.
There it is. Yep.
Yeah.
Okay, might have just been a little lag there. Okay.
Yeah.
So the topic is, generally mental health supports for people with intellectual and developmental disabilities. Generally speaking, just as a matter of semantics, we have generally, you used to call it dual diagnosis, but generally what we're saying now is that people with intellectual or developmental disabilities have a co-occurring mental health conditions. So dual diagnosis can mean various things, but in the field of mental health, dual diagnosis generally means a mental health condition, a mental health diagnosis, and substance use or substance abuse disorder of some kind. So we've kind of gotten a little bit more away from dual diagnosis and into just co-occurring conditions. So still the same thing though, which is that it can make a situation more complex. It can be more difficult for a person to access services, the right services, and all of those things. So the idea here tonight is to go through an overview of these diagnoses, and then to talk about what it looks like to some extent, and who's involved in supporting people with IDD and co-occurring mental health conditions, And then, of course, we'll bring it into the REACH realm, because REACH is a big part of making sure that folks with IDD and mental health issues are getting the supports, the right supports, the appropriate amount of supports, and also crisis supports, which we'll get into. So first, just for some definitions, that's Virginia, not Virginia. Sorry about the misspelling there. But in Virginia, developmental disability is a severe and chronic disability of an individual that's attributed to mental or physical impairment, or a combination of impairments that are manifested before the age of 22. So we just want to, make sure we're talking about the same things and using the same language, so that any words or terms that are used tonight are very clear to everybody. So first and foremost, the overarching umbrella for the field that we work in at REACH, and the overarching field in general, is called developmental disabilities. So these disabilities can result in substantial limitations, and that's on a spectrum. There could be different, different severity levels of the limitations, but in general, it's going to cause some sort of substantial limitation, or one that does require some sort of remediation or support or extra services and things of that nature. And generally speaking, these are diagnosed as professionals. So, for example, a medical doctor. That could be a pediatrician, obviously, because we're talking about prior to the age of 22. It could be a psychologist. So there could be multiple professionals, licensed professionals, who would diagnose one of these conditions. When it comes to mental health, which we'll get to, that's not considered a developmental disability, but there could be some overlap between these two things. Common developmental disabilities, and that's really just a list of about 8 or 10, when there really literally are hundreds of them. So just to give you an idea of what a developmental disability, what specifically some might be, you see some that might look familiar to you, especially cerebral palsy, Down syndrome, and then of course we have on the list autism and intellectual disability. And those are the ones, those are the disabilities that we are predominantly supporting when we talk about the field of IDD, or intellectual and developmental disabilities. We're talking about intellectual disability and autism. So we'll get into a little bit here about both of those. But you can see that even, for example, ADD and ADHD are developmental disabilities, because they do emerge prior to the age of 22. Many times those are diagnosed before the age of 22. So they would be considered developmental disabilities. A different kind of, the difference is that like REACH, for example, or other IDD support providers or service providers don't necessarily provide services to someone who only has a diagnosis of ADD or ADHD. So in our field, generally speaking, somebody has to have a diagnosis of autism in order to qualify for services, and that's in line with the waivers in Virginia as well. So it's kind of in that same realm. So, intellectual disability. Many of you may already know what that is, but just for, again, the sake of making sure we're all kind of on the same page, an intellectual disability is characterized by significant limitations in intellectual functioning and adaptive behavior. So it's necessary to have those limitations, that disability, if you will, manifested in not only in the intellectual functioning, which is measured through an IQ test, but also in adaptive behavior. Because there could be people who have kind of a low IQ or borderline IQ of, maybe 70 or 69 IQ, who actually are able to adapt and able to function fairly well. And so, some people may not qualify perhaps for a certain service or a certain funding source because they're not necessarily meeting it on both ends of that. But the intellectual functioning and the adaptive behavior and the disability usually originates before the age of 18, or is, generally speaking, a person has an intellectual disability likely either in utero or not long after birth. And so it's primarily going to be a diagnosis that comes very early, within the first 10 years of life. Generally speaking, this is about 1% of the population. And the reference there, AAIDD, is the American Association for Intellectual and Developmental Disabilities. So intellectual functioning, as I was saying, is measured through an IQ test. So intelligence quotient. Generally speaking, that's going to be below 70 or below is the qualification for an intellectual disability. And then there are levels: mild, moderate, severe, and profound. And I'm not going to go deeper into that, but just to explain that that's where those terms come from, based on the level of IQ that the person has tested at. And then adaptive behavior is going to be conceptual, social, practical skills that a person, and typically in society is going to have to know and perform in order to function in life. So this could be things that have to do with, your ability to get dressed, to do your own hygiene, personal care of different sorts, care of your money, going places. Can you drive, or are you dependent on others for transportation? And so all of these kinds of things that we do as part of daily functioning, that also has there are certain deficits there. And with those deficits, that's another way of assessing for intellectual disability. And it complements and goes along with the IQ score as well. Then typically a person would then have a diagnosis of an intellectual disability. So when we're talking about developmental disabilities, the other very predominant one that we support through REACH and other aspects of the field of IDD is autism spectrum disorder. Of course, probably everybody who's in this training tonight has heard of it, and maybe has very close personal experience with it. But it's one of, as I said, hundreds of developmental disabilities. It can cause significant social, communication, and behavioral challenges. Some of the parts of the diagnostic criteria for it, in other words, the way that a person might be diagnosed is because there are deficits in some of the communication skills, some of the social interaction abilities, and there could be restricted and repetitive patterns of behavior or interests or activities. So these are just kind of some of the major hallmark kind of characteristics of autism spectrum disorder. And with enough assessment, these things can be determined, and the person can be diagnosed with autism spectrum disorder. So that moves us into another definition, which is mental illness. Now, there are times that there are people, and very likely not those of us who are in this training tonight, but there are still people in our communities who wouldn't be able to differentiate between a mental illness and intellectual disability, for example, and they might just lump everybody into one category. What we need to kind of split the hairs here, because the major thing we're going to be talking about is how mental health manifests in people with intellectual and developmental disabilities, but also how that looks different and how that could look different in the kinds of services they receive as well. So first, to define mental illness, it's generally, it's a condition that impacts a person's thinking, feeling, and mood. And it might affect their ability to relate to others and function on a daily basis. So mental illness is, many times it's psychiatric in nature, which means that it's rooted in sort of brain functioning and brain chemistry, even, we would say. And these things affect a person's thinking, feeling, or mood. And this is something that can affect a much wider number of people across the general population. So whereas about 1% or fewer of people in the general population might be diagnosed with an intellectual disability, a mental health condition can affect as many as 20% of the people in our community. So those are things that, we're not talking about like a serious mental illness, like a severe mental illness like schizophrenia, which is much more rare. But also included in these numbers would be things like anxiety disorders or major depressive disorder or other kinds of mood or anxiety-based conditions. So we know people who have these conditions. We might be people who have these conditions ourselves. And as we're seeing in the trend right now is that there are even more young people and adults who are being diagnosed with these conditions. So it's much wider swath of people who might be have a diagnosis of a mental illness. And you might say, is that an illness? Is it a condition? The wording we can kind of jostle with a little bit, but either way, it comes from the same place, which is a diagnostic manual where a psychiatrist or a psychologist or a licensed clinical social worker or a licensed professional counselor. These are the practitioners and professionals who can diagnose these things. Also, psychiatric nurse practitioners, I need to add, because there are a lot of psychiatric professionals now who aren't doctors, but are nurse practitioners. These are all professionals who can diagnose mental health conditions. So as I said, it could be any of us in this training. It could be people we know and love and are very close to. It manifests differently. So let's kind of take a look at that. Let's kind of look at IDD and mental illness side by side, because that's an important way to kind of make distinctions. So if we're looking at intellectual disability, for example, it's a below average ability to learn and to use information. Okay, so there's also just that cognitive disability, which we talked about when it came to the actual IQ. With mental illness, a person won't necessarily have a below 70 IQ, and the mental processes are more that have to do with inappropriate thoughts and emotions. As I said, how a person thinks, feels, and processes and sees the world and experiences the world. And there's different internal experiences that the person has, but it's not related to their cognitive ability. Okay, so that's a major difference. Intellectual disability diagnosed generally or manifests or emerges before adulthood. Mental illness could be before adulthood, but also could be any time in a person's lifetime. The intellectual IDD, for short, refers to sub-average functional intellect. So as I was saying, that would be average intellect is anywhere from 90 to 110 on an IQ scale. We're talking about 70 and below on an IQ scale. So very low IQ and much more severe cognitive functioning. And as I was saying, mental illness, not necessarily anything to do with intellect. There are people who have IQs and have over history IQs, at the genius level, who also might have a mental health condition. With IDD, it's lifelong. And with mental illness, it can be temporary, it can be cyclic, it can be episodic. For some people, it is lifelong. Once it's diagnosed, once it emerges, it could be a lifelong condition, but not always. Whereas an IDD is lifelong. There is no way to there's remediation, there's habilitation, there's learning that can happen, but a person is going to always need a certain amount of support for that disability. For IDD, the services involve training and education, not medication. It doesn't mean that people with IDD don't take medication. It just means that for the condition of the intellectual disability, for example, or autism, you can't take a pill that is going to kind of remediate the symptoms or the condition, or actually make it kind of subside or even go away. Whereas with mental illness, the primary modes of treatment are therapy and medication part of the treatment for mental illness. Now, of course, there's overlap between these two things, and we'll talk a little bit more about that later. With IDD, it's not psychiatric in nature. Okay, so it's not considered a psychiatric disorder like something like depression, schizophrenia, or bipolar would be. It is in the same book when it comes to diagnostics. Like when, how do you diagnose it? It's in the same book, which is called the Diagnostic and Statistical Manual, that would outline how to diagnose it, but it's not necessarily considered a psychiatric disorder. Impairments in social skills and the ability to adapt to life and to function. They're generally going to be mild to very severe impairments in those areas for IDD. With mental illness, it doesn't necessarily impact a person's social competence or their ability to do some of their daily skills or daily activities of functioning. So it can impact it, but because there's not necessarily a coinciding cognitive disability, a person is going to be able to do a lot of things, but their mental health condition can impede some of that and can certainly impact it, but not necessarily to the degree that it does with a person who has IDD. Generally speaking, with IDD, the behavior is usually rational. What that means is it makes sense for a person who has, let's say, an IQ of 68 and has different adaptive functioning deficits. Their behavior generally falls into some rational categories or rational manifestation. The person is behaving in such a way that it kind of makes sense based on their functioning level, because there are things they don't understand, there are things they still need to learn. So it falls in line with the person who's at a certain developmental level. Whereas with mental illness, the behavior can vacillate and can sometimes be very irrational, but also it can be sort of typical. And so it kind of can be this sort of cyclical thing or this thing that goes back and forth. And some of the things like anxiety disorders, for example, have an irrational aspect to them, but the person is still able to function in various ways. So it's not necessarily based, as I said, in a cognitive disability. And many of the activities of daily living, the person is able to function and do without any difficulty. Okay. Trying to advance the slide. Let's see. Okay. So a brief history of IDD and mental health. So as I proceed here, I want to talk about the fact that there was a time when people didn't even believe that people with intellectual or developmental disabilities could have a mental health condition. They thought that everything was a consequence of their cognitive limitations. So in other words, well, they have ID, therefore that explains everything about their behavior, everything about their mood, everything about their functioning. So mental health diagnoses were not typically given, and kind of the marker is kind of before the 1980s, although people were working on this in the 1970s, and the field was starting to grow and starting to progress to the point that people were starting to realize that it certainly is possible for a person with an intellectual disability to have an actual mental health condition that could be diagnosed and treated. But that took a while. So what was used primarily were restraints, medication, but medication primarily to sort of quiet the person, to kind of restrain their behavior. It's kind of a chemical restraint, if you will, rather than treat an actual mental health condition. And there was also punishment used to control behavior. I'm old enough and have been around long enough, about 33 years now, where I started in 1991, and I can remember some vestiges of some of those old ways of thinking. And I also remember we called the field of behavior, we called it behavior management. And it was that was kind of what we were doing. We thought we were doing. And again, people didn't have ill will or anything. They just called it behavior management because that's what we needed to do. We needed to manage people's behavior. Whereas we weren't looking at maybe some of the multiple contributing factors. And also we thought, well, yeah, we can just manage their behavior. We just have to tweak this or do that. And some of that included punishment. I'm not talking about corporal punishment, but more like we used punishment in behavior plans, and we would take things away from people. And, so and punishment has its place in very rare circumstances, even still in behavioral supports. But that was kind of a go-to, kind of right in the front of the toolbox kind of thing. And then medication was used, as I said, as more of a chemical restraint. So the person might be on Haldol, for example, those are the meds we had back then, the heavy hitters, and that was to just quiet the person's brain, quiet their body, kind of, put them in a bit of a stupor, not so much that they're sleeping all the time, but enough that they're slowed down. So the medication of Haldol wasn't used, for example, because they thought the person might have had a psychiatric condition that would have warranted it. So they wouldn't have had a co-occurring diagnosis of something in the psychotic disorder of some kind that Haldol is used for. So that was kind of the history of things. There was also a time when low IQ was taught to equal mental illness in and of itself. So, there's that as well. There was in the 60s and 70s, again, slowly emerging was evidence that people with ID can have a diagnosis of mental illness. There was increased interest in it. And so for the past 30 or 40 years, it led to this discussion of dual diagnosis. As I was saying, that was kind of the first nomenclature. That was the first name for it, was dual diagnosis. And when you're looking at that from an IDD perspective, it meant person might have had an intellectual disability and or autism, plus they were diagnosed with, let's say, anxiety disorder or major depressive disorder or bipolar disorder. So that was called dual diagnosis. And that's when things really started to get going. And so we started to really focus on the best supports, the best treatment, the best research, and research period just started to even be done for these co-occurring conditions. So that's when we started to really look at a person in a more holistic way. And that's when the concept of biopsychosocial in our field really started to emerge. Biopsychosocial basically means we look at the whole person, we look at all aspects of a person, and we consider that everything could have some impact on a person's functioning, and also the positive things about them as well. So when we do an assessment, we want to make sure it's biopsychosocial. We're looking at the biological parts, the psychological aspects, the social pieces, and so that includes people with intellectual disabilities. Well, as before, like I was saying, everything was attributable to their low IQ or to their diagnosis of an intellectual disability. Therefore, it was all ID. So we weren't looking at these other aspects. And now that started to emerge in a much more robust way. And so organizations actually started to form around this, and this is where NAD, which was called the National Association of Dual Diagnosis, or the Dually Diagnosed, or something along those lines. They now just still call themselves NAD because everyone knows their name, but they've kind of gotten away from the dual diagnosis part, as I was saying, but still a wonderful, wonderful resource. It's and there's a resources at the end of the PowerPoint, but thenad.org is the website, and lots and lots of resources there. They're on the cutting edge of how to they're doing the research. They're doing putting out books and articles and periodicals and all kinds of things about best practices for people with IDD. So as we talk about the diagnosis and how a person would acquire a diagnosis or even the condition. The diagnosis is one thing. The fact that a person is having these symptoms and experiences is the primary concern, right? So there could be many factors that affect and could continue to affect the ability to make that diagnosis, though. So the reason why some people in psychiatry would have said, well, we can't diagnose IDD, or we can't diagnose a mental health condition in somebody who has, let's say, a mild or moderate. We, as practitioners need to rely on a person's ability to express their thoughts and emotions to us. That's a big part of how we diagnose, is based on what the person is telling us about what they're thinking and feeling. And so we know that many people with IDD, not all, but many people have difficulties with expressing themselves. Their expressive language or their expressive communication skills could be very limited, or even if they can talk and have a conversation, it may be difficult for them to put labels on their emotions and different things, so difficult to diagnose it if you're just relying on the person to kind of express their thoughts and feelings, because they're going to have some difficulties doing that. Also, people with ID might hide their disability because they just kind of want to fit in, and they already are aware perhaps of the fact that they're different. They may not want to admit to anything more than, you know, what the disability they already have, or things that they're thinking, or any kinds of symptoms they're having. So they might hold back. They might provide inaccurate information. That could be purposely, but it could also be that they're just inaccurate self-reporters and talking about their lives and answering questions. So because of that cognitive disability, that can make it more difficult for them to talk to a mental health professional. The mental health conditions might be expressed differently in persons with ID. Now, there's a whole training I can do on that, and we don't have time for that tonight. But I've even done 3 days worth of training on IDD and mental health. And so in that training is embedded, a large part of that is like, how does it look different in a person with IDD? How can certain mental health conditions manifest a little differently or a lot differently? So that unless the mental health professional, the psychiatrist, the clinical social worker, the psychologist, unless they are aware of how mental health conditions can manifest differently in a person with ID, they're not necessarily going to be able to diagnose it, because they're looking for those specific slices of symptoms that they always look for in the general population, but they without understanding that they need to look for it a little differently, and it might look differently in a person with ID. So that can also hinder the diagnostic part. So there's also this concept called diagnostic overshadowing, which is not as prevalent as it once was. When this term was coined in the 1980s by a professor at Ohio State University. He was basically saying that the clinician might overlook other psychopathology or other symptoms, let's say, because of the ID. And so ID just explains everything. That would basically be what diagnostic overshadowing means. So a quick couple of takeaways here, because I know if you're listening, you'd want to know, well, what does this mean? What are the implications for the person I love and I care for or I support? It would mean that we have to be good advocates first and foremost when we're bringing someone we love and care for to a mental health professional. And we have to advocate based on not only just our feelings about the person, like, I really think there's something going on here, I want you to diagnose it, or I want you to help us figure it out. But we also have to advocate from an educated standpoint, which means that professionals in this field, supporters, caregivers, should really try to do their best to understand some of these how mental health conditions can manifest or look differently in persons with intellectual disabilities. Because if we can understand it, then we can pass it on to someone else. Or we can help the person express themselves about their thoughts and feelings, or we can bring the data with us, or we can bring the information with us when we're going to go to have somebody assessed for a potential condition or situation. So we can be helpful to make some of these these things that are barriers to be less barriers, or we can knock down some of those barriers potentially. Back to the concept of diagnostic overshadowing. Again, this is still at play, not as much as it used to be, but there are still some mental health professionals who would, they just, would see everything through the lens of ID because they just don't necessarily understand how mental illness manifests in ID. So what we'd want to say to them is that severe behavioral disturbances are not simply a typical characteristic of ID. So if a person is going to a new mental health professional for an assessment of some kind or an evaluation, one thing we want to say is that just because a person has ID doesn't mean they're going to have behavior problems, or they're going to manifest with challenging behavior, or that they're going to have all these behavioral disturbances in their lives. That ID and behavioral problems are not always do not always coincide. There are many people with ID who don't have significant behavioral problems. So if somebody's going to get an evaluation, many times it's because they're manifesting some behavior that is problematic at a pretty intense level. So what we want to tell the mental health professional, or what we want to help educate people out there, is that just because they have ID doesn't mean they're going to have behavioral problems, and vice versa. People can have behavioral problems without having an intellectual disability. We see that all the time in our culture. So we'd want to just be good advocates on that. And IQ is not a reason or a cause of a mental health condition or a behavior problem, as I was saying. So IQ, or an IQ of 68 can't be a reason that a person has an anxiety disorder or is experiencing anxiety symptoms. Does it contribute potentially to how they got there? Yes, from a psychological standpoint or from an experiential standpoint, they've experienced things that might make them a more anxious person. But there are chemicals in the brain that impact things like bipolar disorder and other mood disorders and anxiety disorders. And that's not because of 65 that their brain chemistry is like that. So we just want to be aware of that ourselves, and we want to help mental health professionals to understand that the best we can. And that's where REACH comes into play. We do try to do a lot of cross training and a lot of planting seeds in mental health areas, so that we're helping mental health professionals of all kinds to understand that these conditions are not attributable to the person's IQ. Just a few statistics here, and there are many statistics on these things, and you can find them in various places. In fact, NAD would be a good place to find some statistics on the co-occurrence of IDD with mental health conditions. But NCI is a National Core Indicators. They take data on a lot of things that have to do with people with IDD. And in 2017 and 2018, they did a study in 35 states where they just collected data on different disorders and different mental health disorders. And so what they ended up with was that they had over 22.5 thousand survey respondents, and more than half of them had met criteria for approximately 48% met the criteria for one of those mental health conditions. In the general population, that's anywhere from 15 to 19%. As I said earlier, 1 in 5 is sometimes a number that's used. 20% is kind of a ballpark figure for mental health conditions in the general population. But it's more than twice that, obviously, in IDD. Now, you might find other studies that would say, it's lower than that. Generally speaking, and this was I just pulled out the National Core Indicators because I wanted to use that as a marker. But in some other trainings I've done, the number that's landed on sometimes is anywhere from 30 to 35%, and somewhere in the ballpark of 33%. So still, that's more than the prevalence in the general population. So just to review and recap that, I guess what we could say is, based on which source you're looking at, anywhere from 30-ish% to 48-ish% of people with IDD would have a co-occurring diagnosed mental health condition. Okay. Now, that also means that people are actually getting diagnoses now. So if you looked at that in the 90s, that would have been a very, very low number in terms of the diagnosis, because they weren't getting the diagnoses. So there's at least one good thing about this, is that maybe it means that we've done better with the diagnostics, and the mental health professionals are diagnosing it now. So there's a lot of variables that play into that. So it's not just that, but at least we're acknowledging that people with IDD have co-occurring mental health conditions. So we'll go in real quickly because we want to get into the next portion, but some possible factors for mental disorders. And so these tables here, and I'm not going to go through every single word that's on these. But it's there for your resource. But and the source of this is intellectualdisability.info, but also these, you can find this in NAD resources as well. A training that I do has very similar factors for mental disorders. For in the general population, that's going to be on the left, and then for people with IDD, what are some even additional factors or some complicating factors that can make it even more likely that a person could end up with a mental health condition? So on the left, you'll see, some of the typical things about why people in the general population might have a mental health condition diagnosed, or struggle with a mental health condition. And it can be any of those things that are listed there. Okay, so like a family and genetic history, for example. We know that if both parents have bipolar disorder, for example, the children have a higher likelihood of having bipolar disorder. Okay, it just kind of makes sense, right? Or there are certain neurological disorders that lend themselves to mental health conditions, physical conditions. Alcohol and illicit drug use can lead to a mental health condition. So many of these things are true for people with ID and all the other things you see listed there. So like a behavioral phenotype. So not to get too fancy here, but a phenotype just means a cluster of characteristics. Okay, so behavioral characteristics that might go along with certain genetic conditions or disorders. We know that for example, there are certain behavioral characteristics attached to Down syndrome. So that might make it more likely that a person in the long run could also have a mental health condition that manifests co-occurring with that already existing behavioral phenotype that the person has. There could be other kinds of neurological or metabolic or other kinds of causes of that from the intellectual disability that could have been lended itself to brain changes that could lead to chemical differences or neurological differences in the person with IDD that could be connected to certain mental health conditions. The medications that a person is prescribed, the drug interactions. So all of these different things that could be related to these intellectual disabilities could also be related to mental health conditions. In the whole population, adverse life experiences that have to do with, a person's confidence, self-esteem, coping, trauma. All these things can affect anybody in the general population. But when you look at people with IDD, they have higher rates of trauma. They have higher rates of abuse and neglect. They have higher rates of bullying and harassment, exploitation, you name it. They have higher rates of it. And therefore, if it's already a possible factor that could contribute to a mental health condition in the general population, how much more could it also be a contributing factor for somebody who has an intellectual disability, who experiences these things at much higher levels or even higher rates? So this is these are things that are biopsychosocial in nature. It could be something that's already built in through the genetic condition that then psychologically impacts the person because they were bullied or they were abused, that then socially has an impact because then they're isolated or they are they're mistreated in their social networks and things. So all of it kind of runs together and could make it more likely that the person has these psychological factors that could impact whether or not they're going to have a mental health condition. And then, of course, there are the other social factors. And you see many of those things listed on the left can be any of us, but then also the things on the right that could be more pronounced, that are more pronounced for a person with for persons with intellectual disabilities. They have much more changes in their lives. Their life events are much more topsy-turvy because of their family situations, because they move from place to place, possibly. They're more likely to be in foster care situations. They're more likely to be on the lower end of the socioeconomic spectrum. They're more likely to have environments socially that are not as enriching, that are not as supportive. They're less likely to have a rich friend network, and to experience supports in that way. There's more stigma, there's more social exclusion. So all of these things are going to compound a person's potential to then have a mental health condition. So in summary, there's a higher prevalence of mental illness among people with intellectual disabilities, and it's explained, as just reviewed, in biopsychosocial terms. So therefore, if the issue is biopsychosocial, the approach in assessing and evaluating and treating and supporting should be biopsychosocial, which means that it needs to be very robust. We can't just say that person has ID, that explains everything. So we want to make sure that the assessments we're doing, the evaluations we're doing are that have that breadth of biopsychosocial all across it, and that the professionals who are doing those evaluations understand that that when we're doing these evaluations and coming up with treatment plans and support plans, that we need to look at all aspects of that person's life and assure that we're not leaving things out just because the person has an intellectual disability. So what this means is there's got to be a lot of collaboration across service systems and support systems and disciplines. We call that the multidisciplinary approach. So that means that all people from all different aspects of mental health and IDD and as well as the psychiatric world, we're all kind of talking to one another. We're all trying to educate each other, and we're all working well together. We're sharing resources, whether that's time or whether that's money, or literally in the same buildings, so that we're all kind of working together, seeing one another, and trying to come up with multidisciplinary approaches to these issues. The assessment needs to be biopsychosocial, as I said. We need to make sure that we have the right behavioral and mental health assessment planning and implementation. It needs to be improving. We're still worlds away where we were years and years ago, so we've made huge strides. And I can tell you across 33 years how much, I mean, I can attest to that, the big difference from when I first started in this field. And so we need to keep doing that. We need to keep working on making assessment better, and doing our treatment planning and our support planning in ways that really reaches across all those different disciplines. We need to continuously learn ourselves. We need to do cross training. You all being here tonight is an excellent example of how I hope you're learning some things tonight that you're going to be able to use. You're going to be able to help you advocate for the person that you love or the person you're supporting. And those of us who are in the field need to continuously learn. We need to stay up on the current trends in the field. We need to be letting the folks from mental health need to be receptive to IDD folks, kind of conversing and training and educating, and vice versa. very willing and open to mental health professionals teaching us so that we can understand their service system, but also understand so we can do this collaboration when it comes to assessment. REACH is a perfect example of how the two blend together, and we'll get to that in a minute. There also needs to be the person-centered piece. So whatever we do, it can't be a cookie cutter, one size fits all. We have to look at each individual as an individual person who requires an individual approach. So person-centered thinking, person-centered planning, and resources need to be a big part of the overall plan. All right, so that brings us to the REACH discussion. It's a good segue because we just talked about systems. And so REACH is a statewide system. It's a regional system, and it also gets involved in other systems. So we're really, in many ways, REACH is a bridge between IDD and mental health. It kind of brings things into one sort of package that helps the folks who have the most complex behavioral needs in our community as a manifestation of maybe mental health conditions or other things, that it allows them to have the services they need. And we are kind of the de facto experts in this crossing over and cross collaboration between IDD and mental health and challenging behavior. The mission statement is listed there, is to help individuals with developmental disabilities and intellectual disabilities to be supported. And that kind of support needs to allow them to live in the most inclusive life, in the most inclusive way possible in the community. So because REACH was born out of the deinstitutionalization that happened in Virginia, going on 10 years ago now, it started, I'm sorry, 12 years ago now, because REACH was kind of born out of that. So the idea was that REACH needed to be there. There needed to be a safety net for folks who would normally have been in the institution and were in the institutional settings, and we're going to live in the community because it's their right. It's their civil right to live in the community. Yet they were going to have some very complex needs, and so REACH came out of that. And was one way that the state was going to assure that people were going to be able to live in the community in an inclusive way, and that they were going to get effective services, especially when it came to crisis stabilization, intervention, and prevention. So that's the REACH mission, is to provide that so that people stay in the community and they're living and thriving in the community. REACH is a regional program, as I was saying, and it sort of parallels the DBHDS regions, which are 1, 2, 3, 4, and 5. My colleagues in the other regions can tell me whether or not the name is right when it comes to, like, is it a number 1 or is it a Roman numeral 1, or because we've gone through a lot of iterations of this. But basically, there are 5 regions in the state, and we'll towards the end of this section, we'll get into those localities that fall into those regions, and some of my REACH colleagues can be helpful with that as well. So REACH serves a target population of adults and children with co-occurring diagnoses of a developmental disability, primarily ID and autism, and behavioral health needs. And they're going to present with challenging behaviors. Typically, that's going to be the one of the primary ways, or one of the primary sort of on-ramps to REACH, is that a person is manifesting very challenging behavior and very complex behavior, and they also have, perhaps they already have or might have a co-occurring mental health condition. The mission of REACH, again, is that we want to collaborate. So in order to do what we do, we have to collaborate with other agencies and support systems and families, and with the individuals themselves who are receiving these services. So we have to find a way to serve all those individuals with developmental disabilities who are at risk for behavioral and/or mental health crises, and in the old days might have been institutionalized or gone to an institutional setting as a result. We want to make sure that folks are staying in the community setting. So we're committed to developing the interventions to support the individual and their system of support in service. So that system, the word system is used quite a bit in REACH. The system means, you know, a system could be lots of different things. For a person, it could just be their family because that's all they have. Or for another person, it could be their family and their CSB case manager. It could be that they're also connected to a school system. It could be that they also have that they're living in a group home. But for folks who don't have the waiver yet and don't have a lot of those services, they're going to have fewer members of their system, but we're going to work with whoever is a part of that system. Another thing that REACH can do is to try to help with some of the linking to the other parts of the systems that a person might need. There's no guarantee that we can do that, but we certainly will try our best to advocate for that. As you heard earlier, REACH stands for the letters in the name stand for something, and R is regional, but the other letters stand for educate, assess, crisis, and habilitate. So if we go quickly through these different parts of what REACH does, I think it can be helpful to understand at a deeper layer, like who's involved, what we do, and what you could expect. Also, what we could talk about is what you might not expect, because we want to make sure that the expectations are very clear on your part of what REACH does, but also what REACH doesn't do. It's important to know that because we want to be a part of the solutions, but there are things that we don't do. So we want to be clear about that. So in the education piece, tonight is an example of the educate part, which means that we will go to people, we will go to systems, and we will go to organizations and do training. We offer a lot of different training in our different regions. I can't speak for all of the regions, obviously, but in Region 4, we have a list of trainings that we provide, that we'll provide through the entire year, that people can sign up for. And most of them are done through Zoom. Occasionally we do something. I don't know why, but my slides are going on their own for some reason. So I'm gonna, if it hops, I'm gonna bring it back. So sorry about that. But we have a lot of different trainings available. I know that the other regions do as well. That's part of what we're supposed to do. It's part of the mission, is to educate. So that could be educating like tonight. It could be family members. It could be providers on a wide range of topics. And by providers, I mean support providers. That could be like group homes, day supports, sponsored placements. You have those community coaching services. You've got in-home residential. And it could be to other providers. It could be to the mental health system. It could be to schools. It could be law enforcement. So we do trainings with the local law enforcement in Region 4, where we're going out and training them on what REACH does. Sometimes we do trainings that will help them to understand mental health conditions and IDD better, so that they're better able to respond to a crisis. So those are the kinds of things we do with law enforcement. And then, we'll basically train and educate anybody who will listen. And so as long as it fits within our mission, we'll find a way to do it, to do education around it. The assessment part takes a variety of different aspects as well, but certainly in a crisis situation. So when a crisis is occurring, what does a crisis look like? So let's talk about what a crisis is, first of all. A crisis is anything to the extent that anything that a person is manifesting in their behavior or in other symptoms or in other manifestations of their functioning, that becomes such that the supporters who are right with that person are really struggling to support the person through the event or the situation. So it can be an event like right now. Joey he's yelling and screaming. He's now out in the street. He's damaging property. Okay, so that is an acute crisis situation. It's an actual event. Whereas crisis could also mean that Joey seems to just be looking different, acting differently. He's up and down in his mood. His behavior is changing. We're concerned about it. And we don't think we have enough resources where Joey is right now to handle this ourselves. So crisis basically is that point at which a system of support feels like they're bending so much that they might even break, and they don't have the resources right there with them to be able to respond to the situation in a way that's going to keep Joey safe, healthy, and well, and to keep others safe and healthy. So that would be considered a crisis, kind of, rising to the level of a crisis or a potential crisis. It could be that they're manifesting certain mental health symptoms that aren't necessarily typical for that person. Maybe it's different than what they look like on a day-to-day basis. Or they have a mental health diagnosis, but their symptoms look even worse or more pronounced, or they're happening more or more intensely. Their behavioral functioning has changed. So it's becoming, if Joey is somebody who has a big, sort of a verbal outburst, maybe, twice a month, now Joey seems to be doing this 2 to 3 or 4 times a week. So there's a clear change in his behavioral functioning. The environment is changing. So the environment is becoming less supportive. Maybe there are changes in the environment. Joey's abused. Maybe there's neglect going on. There could be he's hopping around to different schools, so those kinds of changes in environment, or he doesn't have a settled place to live. So there could be various things that are changing for Joey around him as well. The support system surrounding him is losing ground, or it's not as strong as it once was, or there are support providers who are dropping out. Maybe there are medical issues as well that are impacting the person. Now, what would not be a crisis, for example? Well, Joey's typical behavior, he yells sometimes, we don't like it. It can be irritating. It can be disruptive, but it's not that frequent. It's not really something we're not able to handle. As much as it gets on my nerves as his mother or father or, support provider, we're handling it. It's something that Joey does. Would we like it to change? Possibly. Maybe we get a behavior specialist to come in. But is it an actual crisis? Do we need to call REACH? Do we need to call in other mental health professionals? That's up for the team to decide. But is it an actual crisis? Probably not. But if it's drastically, even in a moment or over time, that might be the point at which to contact REACH, and we will do an assessment in all these different aspects. The crisis services are 24/7 crisis response. So there's a person who will answer the phone number whenever you call it, which we'll see the numbers here towards the end of the presentation. So you call the number, you're going to get an actual person on the line who's going to ask you questions and is just going to kind of what we call triage. They're going to ask questions to try to do a sort of very quick assessment of the situation to determine what the next step should be. What a next step could be stabilization. So that stabilization might have to happen right now during the crisis. So the person who's on the other end of the phone might talk you through that stabilization process, or they might have to do a face-to-face to help that to happen. They might come out to where the person is, and they might help other systems to assess. So if the person is being assessed by the police, for example, or they're being assessed at a hospital in an emergency department, the REACH personnel might do it over the phone or might go out to actually face-to-face do kind of some assessment with the other folks doing an evaluation as well. And that makes that evaluation much more complete and appropriate. So they may go out and do some coaching and mentoring in the moment with the person's system of support. So if the person on the line is hearing enough that says, let me come out there and let me do an assessment in the situation, they might actually coach people in the moment to of how to kind of respond to this person. Now, one thing that REACH will not do is say, okay, you all, group home staff, you all leave, and I'll take over. Or parents, you can go to the coffee shop and get a break while I'm here. That's not going to happen. That's not something that REACH can do. We can't replace the supporters or caregivers. We're there, though, to help coach the process, to help coach the person to de-escalate, but we're not there to replace anybody else. So that's a very, very important distinction that needs to be made, because we don't want some misinterpretation of what REACH services are. We don't want expectations to be different than what they really should be. The habilitate part of the letters, habilitate basically means it's different than rehabilitate. Rehabilitate means to teach a person over again, or to get them back to where they were, whereas habilitate means to get them back to them to a point in the first place. So habilitation, it's a word that's been used in IDD for a long time. We used to write what was called IHPs, individual habilitation plans. We hardly use that word anymore, but those of us who have been around a long time understand what the word habilitate means. It means to teach, to train, to effectively help a person to gain skills in all different areas. Okay, but the primary things that REACH is going to work on with habilitation is we're going to try to help the person to gain skills that will decrease the likelihood of a crisis in the future. So prevent a crisis is kind of what these skills, that a person develops the skills so that they won't have as many behavioral or mental health crises. We're also, of course, going to be educating on that first line. We're going to be in that first column. We're going to be educating the person around the individual. But when it comes to the individual, that's the habilitation part. So we're going to do some person-centered assessment. We're going to be able to do some behavioral assessment of various kinds and various levels. We're going to hopefully teach a person based on where they are now, try to some sort of plan that helps them to develop the skills they need when it comes to things like coping, stress tolerance, functional skills that would be appropriate to help them to be able to function better in their community and in their community environments. And we're also going to help to identify those interests and those areas where the person really wants to grow. Now, so I say that, and I say that, we get to know the person. It's like, maybe this person could be working. So we might advocate for that, or we might advocate for ways to link the person with things, or what are some things the person needs to learn that that REACH can be helpful with when it comes to them getting a job. Maybe their behavior or their mental health condition is a current barrier. Is there something REACH can be doing to help with that? We don't provide long-term services, so we're not going to be with the person for months and months and months and years necessarily. But in the short time that we are providing services, there are things that we can be advocating for, and there are things we can be identifying as important things for the person to learn. So who does REACH serve? Adults and children. So it's from very young age all the way to old age. They have a developmental disability. That could be an intellectual disability. It could be autism. It could be both, because some people have both. But autism itself is a qualifying diagnosis, or qualifying that does qualify a person for REACH services. They also have to have something else going on, though. So there has to be the mental health condition or a behavioral disorder or behavior problems that are causing problems enough that there's a risk involved. There's a risk for a crisis event, or they're actually, as I said, they're actually in the midst of a crisis event, and you're calling the hotline because there is something very serious going on behaviorally, or their mental health is decompensating significantly. And we provide the support system surrounding the individual. Will also receive services, and that could include the family, providers, faith groups, other people who have contact with the individual, their natural supports, their day programs. So there could be lots and lots of others who are involved, and we're going to help support all those systems. Now, if a person doesn't have the waiver and doesn't have some of these paid service providers, then we're going to do our best to support the people who are right there with the individual. And maybe we can help with some linking. We're not case management services on a long-term basis, but we certainly, if we see, if we have contact with an individual who lives with their family and they're not connected to other services, we're certainly going to not just leave it in that situation. We're going to try to help with that linking. So that will certainly be a part of what REACH can do, but we're not just a service all on our own. So we're not going to come out for the next 5 weeks and provide in-home, services. That's not something we do. But can we help to maybe get to that next level? Yeah, we can help make recommendations and maybe even some phone calls, or tell you who to call, or how to access services. So certainly. Now, when it comes to the mental health parts, that's where we should really shine. If you to someone who when we get involved, we think, oh, there's some mental health stuff going on here. We're going to, in our assessment, that stuff is going to rise to the top and rise to the surface. And then we're going to say, okay, now these are mental health professionals you should be considering. And that's where the different REACH regions would be experts in where those services are located in your area. Some areas are going to have more service, potential than others. Southwest Virginia might have fewer mental health providers than Richmond, but REACH is there to kind of help to navigate that to some extent, or at least put you in touch with the right people. So that's a big part of what we do. That's a part of that educate section that we were talking about. So referrals are made, in multiple ways, but they can be made by just about anybody, including the individual. The individual can call the hotline and say, I'm really feeling bad, or I feel like I'm suicidal. I'm having problems. But that could be a family member. It could be emergency services from a CSB. It could be the support coordinators, case managers, could be anybody, literally. The reasons for the referral, again, there has to be something going on that has some gravity to it, some intensity to it, and there's risk involved. Perhaps their home placement is very tenuous. Their school placement is not so good. They're losing jobs. Perhaps there's a history of this. There's complex kinds of issues going on. There's significant deterioration in functioning. So again, what I was saying was, Joey yells about twice a month when he gets upset about something. Okay. Well, what we're seeing now is it's twice a day. He's having more blow-ups at a much higher rate. We're seeing that he's not sleeping as well as he used to. He's not doing things he used to enjoy doing. Okay, well, that's a significant deterioration or change in his functioning. So that has to be, not has to be, but that could be another thing that's present that would make you want to make a referral. There's behavior that has resulted in contact with law enforcement or even going to jail. That's a very significant problem, and one that if a person with IDD is having contact with law enforcement because of their behavior, that's absolutely a situation where REACH needs to be involved. So sometimes the police themselves will call REACH. The jail systems might call REACH. Or if they ended up going to a hospital with the police, the hospital will call REACH. But someone along that line needs to get in touch with REACH if the person has IDD and is interfacing with these systems. So again, who works with REACH? They're listing there, just some of the people or entities. For providers and families, contact REACH as soon as you can. If you're really concerned about the direction of a situation, contact REACH. Again, we don't replace the staff or the family, but we can support. We can help with de-escalation, either over the phone or in person. We can help you and coach you through the situation. Emergency services, we're going to work very closely with ES departments. And so if someone is getting an assessment done by an emergency services department, we're there to help with that. If that person has an intellectual or developmental disability, autism, ID, sometimes a person is going to get an assessment, a pretty deep down assessment that determines that there's enough going on here that the person maybe should be hospitalized for a psychiatric reason. That's called a TDO, when a person is given a temporary, issued a temporary detaining order. And so that TDO is something that could be done in conjunction with discussion with REACH who are present. The REACH team, though, is going to want to work on, making the hospitalization, helping to the person not to go to the hospital. Okay, we're trying to divert hospitalizations if possible. Now, if a person truly needs to be hospitalized because they're having a psychiatric crisis, and this is truly a mental health condition that would warrant a mental health treatment acutely, which would mean in a hospital, in inpatient setting, then yeah, that totally makes sense. But if there's a behavioral component to this, or it's not so psychiatric that the person needs to be in a hospital to get their medications looked at, or to do some other kind of treatment planning in a hospital, we might try to divert that hospitalization. That's part of our goal, is to keep people out of hospitals when it can be done. So what we're going to try to do is to help come up with alternatives. If a person is in a psychiatric hospital or placement, we're going to help to transition that person back into the community. So we're going to provide technical assistance to the hospital staff. We're going to participate in treatment team meetings. We're going to try to do what we can to help build that treatment plan that makes sense for that person, and then help with their transition back to the community. The REACH Mobile Crisis Response, just to kind of go a little bit more in depth with that, it's available, as I said, 24 hours a day, 7 days a week. It's something that you're going to get a live person on the other end, which is something that's not always the case these days when we make phone calls and are trying to get support as a customer in any kind of way. But in this case, you're going to get a real person who's going to triage. As I said, that's just a fancy way of saying, going to kind of do a quick assessment of the situation. They're going to ask questions. They're going to document it, and that's going to become a formal assessment document. They may do a face-to-face, to meet the person where they are out in the community. There's going to be an intake that's done as a part of that assessment process. If a person isn't currently a REACH client, that crisis assessment is going to also trigger an intake process that person will then become a REACH client for a period of time. And so, what that's going to do is trigger other potential services. So the adults and the children who are coming through the referral line could get crisis assessment, as I said, done in their community. They could also get crisis stabilization. So crisis stabilization at this point now is, how do we help this situation to get back to normal? How do we stabilize the situation and the person? That could also include the people who are supporting the person. How do we get it back to normal the best way we can? And so that's stabilization. So that can happen in the person's home, potentially. It could happen through what we'd call mobile support services. So over a period of days, maybe the person is going to get somebody from REACH coming out there to their home, maybe to their day support, wherever the person is, to do some sessions with them and try to do some stabilization in place. But there could also be crisis stabilization that happens in one of our crisis therapeutic houses, where the person is going to leave their home after a good assessment is done and some medical screening is done, and they might go to one of our crisis homes. And so every region has an adult crisis therapeutic home, and 2 of the regions have homes for children as well, regions 2 and region 2 and region 4. So that's a possibility as well, if it's deemed that necessary and could be therapeutic for the person to go to one of our homes to get some stabilization done in a short-term basis, by the way. Short-term meaning 15 days and at the most 30 days for adults. And generally for kids, we try to keep those placements and those admissions much shorter, because it's such a disruption for a kid to be out of school, to be out of their home. It can be more traumatic. So generally speaking, kids are going to have shorter shorter admissions to the home, whereas adults could have longer ones, but still 7 to 10 days, 10 to 14 days. And then we start to we start discharge planning immediately, but we want it to be therapeutic, but we don't want it to become counter therapeutic. So if a person is at one of our houses and it's getting kind of long and there's no place for them to go, we start to get concerned that the person is going to kind of re-escalate or the situation is going to unravel. So we're always talking about what comes next for the person. What also happens is the development of a crisis education and prevention plan. So this plan is person-centered. Its strength is, what can I do as the support provider for this person? We identify like what are some of the triggers, what are some of the stressors for the person. The plan can give can spell out like what to do to prevent a crisis, but also can then also talk about what to do when there is a crisis. Who are you going to call? What are you going to do? What are some interventions you can provide and things like that. So that crisis education and prevention plan can be shared with anybody who has contact with that individual. And everybody is also a part of developing that plan. So if everybody on a person's team is their mom and dad and their school teacher, then that's who's going to be a part of developing that plan. If they have a much more robust service system and they go to a day support and they have a group home and other support providers, then they're also going to be obviously a part of developing that plan. And so they're all the ones who are going to implement that plan and to hopefully prevent a crisis, but also so that everybody's responding appropriately if there is a crisis. And then, again, just a sort of like a little flow chart here of the services. You got the 24/7 crisis line. We have the mobile crisis services. We have the response and the assessment that's done. There's therapeutic houses, as I was saying. There's the one for youth and there's the one for adults. Just to reiterate, again, every region has a crisis therapeutic house for adults. 2 of the regions have crisis therapeutic houses for youth, and that's regions 2 and 4. And those regions can take kids from out of region. So we're going to serve certain regions in region 4, and region 2 is going to serve certain regions. My colleagues can correct me if I'm wrong. The region 2 youth therapeutic house serves regions 1 and 2, and the region 4 therapeutic house for kids serves regions 3, 4, and 5. So if I'm incorrect about that, please correct that. But there are all the time we could be taking people from other regions, even in the adult houses. So if let's say the region 5 is full, but there's a person in region 5 who's having a crisis, the region 5 REACH program can look out of region for a potential admission to one of the other houses. So that's a possibility always, because we don't want to just say we're full, therefore there's nothing else we can do. We want to be able to provide an option. The last thing on the list there is the post-crisis follow-up, which a person is going who is in REACH services is going to have a REACH coordinator. It's not a case manager, so we don't want to mix it up with case management. It's a coordinator for REACH services who also then can help to make sure that everybody's talking to one another, that the mental health systems and supports that the person needs are getting put in place. Working with case managers or support coordinators to make sure the person has the supports they need, seeing where REACH services fit in for that person, writing the crisis education and prevention plan, assuring that everybody has a copy of it and knows what to do, and following that person's case for about 3 months to make sure that we're preventing crises that might happen after the crisis that we got involved with. Or let's say the person went to the crisis therapeutic house, they discharged, they're back in their system, they're back in their situation, and so they're not getting crisis stabilization services anymore, but they have the REACH coordinator to, it's, in other words, it's not just we'll drop you off and we're done. The REACH coordinator will now kind of just make sure that things are going well. We'll check in at least once a month for that period of 3 months. And we'll, again, just make sure that the mental health services are in place, or whatever services are in place for that person. So that's where, the other regions come into play in this presentation as well, because we're all here to, to talk with you if you have questions about what services might be available in your regions, whether that's the mental health services, the psychiatric, providers, all the people that, or behavioral consultation services potentially. So we have linkages, we have connections with those providers, and theoretically we might be able to give you the information you would need to make those connections. There are the phone numbers. Now I'm going to ask if anyone from Region 1 REACH is in this meeting. There used to be 2 separate lines, one for adults and children. So I don't know if anyone from REACH could chime in here and tell me if there are two numbers or just one number. Can anyone answer that question? Is Region 1 in the house? Okay. If any of the other regions know, please. But there was a time when there were 2 numbers for Region 1. So I'm sorry, number now?
I think it's just one number now, yes.
I thought it was. Okay. It was too. This is from the training that DBHDS gave us for training on the REACH services. And at that time, when this first started, it was only 2 numbers. So here are the different regions, or different localities that regions serve. I know if you're looking at this on your screen, it's very tiny depending on the region. But Region 1, because there are a lot of smaller communities, they're serving lots and lots of different localities and different CSBs. Region 2, Northern Virginia. Region 2 is Northern Virginia? Yeah, Northern Virginia. A lot of largely populated areas there, especially Fairfax, Loudoun County, and all of those areas. Region 3, again, more rural, lots and lots of geographic area there, multiple CSBs involved. Central Virginia, Region 4, that's who I represent, and 2 of my colleagues who are also in this training tonight. You can see some of the CSBs that are represented there and some of the localities. And then Region 5, which is Eastern, they have a lot of ground to cover out there as well. So lots going on. Okay, so I'm going to stop sharing because this is the point at which, let me go forward to the sources and the resources. There's a list there of things. I didn't just pull some of this information out of my hat. It's definitely, well documented. NAD is listed there. They're part of some of these things that I mentioned. Other websites that were resourced are also there. So I'm going to stop sharing.
I want to get us out here at 8:15, so we are going to thank all of our representatives from REACH. And if you don't mind, we have a survey link, and you guys can document and provide your opinion on tonight's presentation and if it was helpful. And we have a little bit of IFSP council business, and then we will conclude for the night. If you guys, anyone is interested in seeking resources, you can go to My Life, My Community. This recording will be posted to My Life, My Community and to the IFSP Facebook page. Currently, we are recruiting for a self-advocate in the Northern region. So if anyone is interested in serving their region in Northern Virginia, there's a link to the application which closes on March 31st. Save the date, the next IFSP State Council meeting, this is not a public meeting, will occur on April 19th. And then our next Regional Council meeting, which will be a public meeting, is scheduled for May 16th, 2004. If you would like to receive the latest updates from IFSP, you can subscribe to our mail list, and the link is below. Next slide. Thank you to all of our panelists, our main speaker, VJ Petillo, all of our representatives from REACH. We appreciate your time, especially at this hour of the evening, and have great appreciation for the information that you've shared.
Thank you for inviting us.
Thank you. Next. And the survey link is there for your convenience. So thank you all. That is the end of our meeting. If you have other questions that you don't have time to put in chat, you can always send them to IFSP support@dbhds.virginia.gov.
And the
Thank
link,
you.
the link to the survey is also in chat too, if you want to grab it really quick in case for some
Yes.
reason you can't do the QR code. There's also a link. And we
Yes.
really appreciate any feedback you can give us, because we want to hear what was good, helpful for you, and what we can improve on.
Okay, that concludes the meeting.
Thank you, everyone.
Thank you.